This book focused primarily on nutritional psychiatry because it's so missed, but we're not discounting the role of therapy or medicines or nutritional support. They're all important. But without that biological foundation of, your brain working, nothing else makes sense.
Welcome to the Mind Health 360 show. I'm Kirkland Newman, and if you, your loved ones, or clients suffer from mental health issues such as depression, anxiety, insomnia, poor memory, poor attention, mood swings, exhaustion, etc., I interview the leading integrative mental health practitioners from around the world to help you understand the root causes of these symptoms, many of which may surprise you and suggest solutions to help you heal. If you like this interview, please do subscribe and forward to others who might find it helpful. If you want further information, please go to www.mindhealth360.com or find us on social media. So Dr. James Greenblatt, thank you so much for being on the Mind Health 360 show. And I'm really excited. This is the third time that I've actually interviewed you for the show. The first time was on ADHD. The second time was on suicide prevention. And this time is on eating disorders, which I think is such an important topic. And I will introduce you. I know people know you, but I'll quickly introduce you again. You're a pioneer and renowned expert in the field of integrative medicine. You've treated patients since 1988. After receiving your medical degree and completing your psychiatry residency at George Washington University, you completed a fellowship in child and adolescent psychiatry at Johns Hopkins Medical School. You currently serve as Chief Medical Officer at Walden Behavioral Care in Waltham, Massachusetts, and you serve as an assistant clinical professor of psychiatry at Tufts University School of Medicine and Dartmouth College Geisel School of Medicine. You're the author of 7 books, including Finally Focus, the Breakthrough Natural Treatment Plan for ADHD, Nutritional Lithium, A Cinderella Story, Answers to Anorexia, which is the book that we're discussing tonight and which was first published in 2010 and was republished in 2021. Integrative Medicine for Alzheimer's, Integrative Medicine for Binge Eating, and Integrative Medicine for Depression. You're also the founder of Psychiatry Redefined, which is an educational platform dedicated to the transformation of psychiatry. You've lectured internationally on the scientific evidence for nutritional interventions in psychiatry and mental illness. And through 3 decades of practice and research, you're a leading contributor to helping physicians and patients understand the role of personalized medicine for mental illness. So we owe a huge debt of gratitude to your enormous body of work when it comes to integrative mental health. And I, for one, am a huge fan of yours and the work that you've done. So thank you for everything. I think eating disorders is a huge, huge issue. And if I'm not mistaken, it's one of the reasons that led you to integrative mental health in the first place. And I know that your work with eating disorders and eating disordered patients really drove home for you the importance of nutrition for mental health. Do you want to tell us a little bit about how eating disorders was very formative in your career?
Sure. I mean, I think when I started about 25 years ago, focusing almost exclusively on eating disorders, it was just so striking to me that the major aspect of this illness that I was seeing, which was malnutrition and starvation, was not addressed by the traditional treatment model. And I've always been interested in nutrition and brain function and our individual needs. And we just saw it so clearly in our patients struggling with eating disorders, and just became pretty driven over these 25 years to help people try to understand that connection. And the good news is the research is finally caught up across many, many other psychiatric illnesses that nutrition does affect our brain health across all major psychiatric illnesses.
Yeah, it's so true. And, in terms of eating disorders, I mean, I was shocked by the statistics in your book. First of all, it's the highest mortality rate in psychiatric illness, and it's more than 12 times higher than the annual death rate from all other causes combined for young women between 15 and 24. 5 to 10% of those with anorexia die within a decade of the initial diagnosis, and 18 to 20% of those with anorexia die within 2 decades of initial diagnosis, usually from cardiac issues and suicide being between 20 to 50%. And individuals with anorexia are 31 times more likely to make a fatal suicide attempt than the general population. It's also the illness with the highest relapse rate in psychiatry, which is essentially between 33 and 50%, which I found quite shocking. And in the US, 1.2% of the population, and that's boys and girls, men and women, age 15 or older, have anorexia at some point in their lives, which is roughly 3 million people. And you say in your book, the increasing incidence of eating disorders, the younger ages of eating disorder onset, the increasing rates of suicidality among eating disorder population, and extensive waiting lists associated with admission to eating disorder treatment programs around the globe all reflect a model in desperate need of improvement and refinement. Now, I'm quoting that directly from your book. One of the key arguments in your book is really that traditional mainstream approaches to eating disorders are really missing a trick. So they focus on psychotropic medication and therapy, both of which can be useful, especially therapy, but you feel that they very much miss a trick when it comes to nutritional status. Can you tell us a little bit about how you came to that conclusion?
Sure. I mean, originally it was just seeing hundreds and hundreds of patients. They would eat the food that was provided to them in a 24-hour setting. They might restore some weight, but they would go home, lose the weight, because the thoughts never changed, the preoccupation, the rigid thinking, the obsessions about body or size. And that relapse was just part of our treatment. And people were talking about 10 or 20 years of having this illness. And that made no sense to me when we looked at what was right in front of us, which was malnutrition and starvation and malnutrition of multiple minerals, macronutrients, amino acids, and fatty acids. So as we started exploring providing just a nutritional supplementation, which was not originally part of a treatment plan in eating disorder programs, people started getting better, physically better, and less relapse rate. And then, over many years, just working with thousands of patients, the difference is quite striking.
Absolutely. And first of all, just to be clear, in terms of gender differences, there are more women who suffer than men. However, men also do suffer from eating disorders. And you mentioned in your book that, the preoccupation might be slightly different. Women generally want to be thin, whereas men seek to be well-defined, muscles and have sculpted physiques. And some will overexercise and restrict food intake, both women and men. And I just think that's important because, we often think of women, and there's a lot of stigma, I think, around men as well, because they think of it as a female illness. And it's important to point out that that's not always the case. And you also make an interesting point that men tend to show particularly low levels of vitamin D and testosterone. Now, coming back to your point about the nutritional status, I think if we outline the problem is there's no silver bullet to treat eating disorders. The treatment in mainstream psychiatry, as you point out, is, falls short. And I'll quote, you say, neither psychotherapeutic nor behavioral therapies have ever been shown to be consistently effective in double-blind, placebo-controlled trials, which are the gold standard of, clinical trials. Often treatment focuses, as you were saying, on caloric intake, but it's not necessarily the right type of calories which would restore sort of healthy brain function. And so, when we ask why is it that mainstream psychiatry doesn't focus more on nutrition? And you explain this in your book, but do you want to just tell us why you think that is?
Well, there are probably lots of reasons. I think part of it in our community of medical professionals, it's just not part of the pharmaceutical model, the surgical model, so it's not part of the medical model. And the other part that is really frightening is just the lack of training. We do not train physicians in nutrition. There might be an hour course in biochemistry, and we don't train physicians in eating disorders. Sometimes, I give lectures to residents, psychiatry residents in the States at multiple universities in New England. And my hour and a half or 2 hour discussion is often their only educational opportunity to learn about eating disorders. And as you said, the most life-threatening illness in psychiatry, highest risk of suicide, highest stress of caregivers, and we're providing a few hours of training.
Yeah, which is just absolutely crazy. The other interesting thing I thought was the comorbidity with substance use disorders. There's a lot of crossover between eating disorders and substance use disorders, so drugs and alcohol. So 50% of people with eating disorders also have a substance use disorder, compared with 9% of the general population. And 35% of people with substance use disorders have an eating disorder, compared to 3% of the general population. So I thought that was very interesting as well. Now, if we look at the root cause, because one of the things I love about functional medicine and integrative medicine is that we really look at the root cause, like what is causing, rather than treating the symptoms. And in analyzing your book, a lot comes out. So first of all, the nutritional deficiencies, as you were talking about. So, you point out really well that the essential nutrients that we get from our food are absolutely essential for our brain health. And the need for these nutrients really increases very, very fast at puberty. And, puberty can be a real sort of problem, because if young people are not eating enough and they're not eating the right kinds of foods, they're not able to nourish their brains and their bodies. And, you mentioned that they add 20% of their adult height, and up to 92% in males, and up to 50% of their adult weight during puberty. And yet they're not necessarily getting the right foods, especially if they're tending to be picky eaters or restrict their eating. And one of the things that I found fascinating in your book was the focus on zinc. So you talk a lot about how zinc deficiency mirrors anorexia symptoms. So decreased appetite, decreased sense of taste and smell, nausea, bloating, problems with digestion, insomnia, depression, attention difficulties, and increased vulnerability to stress. The fascinating thing to me was you were talking about how zinc could lead to loss of appetite, taste, and smell. And it can also negatively impact digestion, which would then lead to a sense of bloating and nausea after eating. So it seems to me, and also you mentioned that it's a very important cofactor in the synthesis of dopamine, which is your motivation neurotransmitter, and serotonin, your sort of happy mood and appetite neurotransmitter, norepinephrine, which is your sort of motivation, again, neurotransmitter. So it seems to me that zinc, as you were saying, is absolutely essential. And the interesting thing is there are a lot of factors that prevent adolescents often from getting enough zinc. Can you tell us a bit more about this? Because I found this really interesting.
Sure. I mean, I'm glad you read the book so well, because that was a beautiful summary, Kirkland, and it is critical, and particularly the younger ages, I think, understand the relationship between zinc could prevent so much of this, what we call morbidity and the tragedy of untreated eating disorders. So as we go through puberty, we have higher needs for just a few nutrients, and zinc is one of them. And pregnancy, you need more zinc. So if we think about, and I use the term perfect storm, we have clearly established there's a genetic vulnerability to anorexia nervosa. So that research has been repeated and now established in the literature. So we have a genetically vulnerable individual who might happen to either go on a vegan diet because their friends are, or just restrict animal products. But either way, they're restricting zinc at a time in their life when they have a higher need for zinc, and that's puberty. And that kind of perfect storm creates a host of physiological problems. As you described, our taste buds are zinc-dependent enzymes, gustin. So we don't taste if we're zinc deficient. We don't digest food well, which means it's easier to walk away or eventually get nauseous and not able to eat. And our brains don't work adequately. Most enzymes in the brain require this mineral zinc. So all these factors come together and eventually set a course for much of what you and I would describe as disordered eating. For some individuals, it just progresses to anorexia nervosa.
Yeah, which is really tragic when you think of the fact that, zinc is such a simple supplement to take, essentially. And you talk also about the causes of zinc deficiency. So you mentioned puberty, stress, being vegetarian, flour-based foods, things like pizzas and pasta, which of course teenagers love, apparently can deplete zinc, BPAs and other environmental toxins. Estrogen and birth control pills, which I found fascinating, can also deplete zinc. High copper from maybe copper tubing, that we get our water from, excessive exercise, sweat. Now, you talk about genetics, and I was interested in that as well, because you mentioned that there is a lot of research that's just come out about the importance of genetics, especially the genes related to metabolism when it comes to anorexia, so much so that I think Professor Bulik at UNC calls anorexia a sort of metabo-psychiatric disorder. So tell us a little bit about the actual genes and the genetic component and aspects of anorexia.
Well, we really don't have details. And it's been pretty clear to us in the field about the genetic. But what Dr. Bulik has done with this international study with thousands and thousands of women with anorexia just kind of established without a doubt that it's a genetic disorder that is biologically based. So it has just kind of helped the eating disorder community acknowledge that it is not a purely psychological illness, that it has a genetically driven, biologically based, and the genes, or at least the cluster of genes, tend to have to do with metabolism, which in our world, in functional medicine, what drives metabolism? The vitamins and minerals that create energy. So it doesn't give us details of how we can detect or treat, but it just kind of helps support this argument we've been trying to make for the past 20 years.
Yeah, which is so important because, it's not just zinc. And you talk about energy production. You mentioned in your book magnesium, which is essential to ATP production. You talk about, proteins and amino acids, which are absolutely essential as building blocks of neurotransmitters, sort of the key neurotransmitters, dopamine, serotonin, or norepinephrine. And, a lot of young people do tend to become vegetarian and vegan and then probably aren't getting enough proteins and amino acids. And, there's a risk of vegetarianism being zinc deficient as well as B12. And you talk about the importance of B12 also in the production of neurotransmitters. You talk about folate and B6. You talk about low digestive enzymes and probiotics, and that being a huge issue also with eating disorders in terms of, starvation leading to low digestive enzymes and gut dysbiosis. Can you tell us a little bit about the mechanism of that and how it works? And also, I'm mentioning a lot of these issues in once, but they're all related to nutrition. And the fact that you mentioned a lot that the eating disorders are essentially often the result of, starvation and malnourishment. And I'll let you talk about the gut and the digestive issues and the sort of important minerals and cofactors. And then after, I want to talk about the root cause of what causes this starvation. So I'll let you.
Sure. So, if we start with back to zinc, and we'll probably keep coming back to zinc, zinc is such an important trace mineral that you need it to make acid in your stomach and all the digestive enzymes in your gut. To digest protein, fats, even carbohydrates. So as zinc deficiency progresses, we have more and more GI disturbance, and then we have a change in diet and a very restrictive diet. And the most significant factor that affects our gut microbiome is a change in diet. Other than something dramatic like antibiotics, but if we change our diet, we're going to change the microbiome. So a restrictive diet, we have good research. Dr. Bulik's group did some, and we have obesity researchers looking at the gut, the microbiome. And we have established clearly that an obese person's microbiome, whether it's a rat or a human, is very different than an anorexic's gut microbiome. And if we transfer or translate, we can change behaviors and we can change eating disorders. So the anorexic patients tend to have a very low variety of gut microbiome, and it's unique. We haven't come to a point where we know exactly the right gut bacteria in terms of treatment, but we know it's so restricting diet is such a disruptive influence on the microbiome. Simply using probiotics and digestive enzymes truly helps many eating disorder patients just feel better, digest their food better, and have less of some of the GI complaints of bloating and indigestion.
So that's fantastic, because essentially, I mean, that's the next part is, we're highlighting the deficiencies that can lead to sort of disordered eating. But at the same time, these are also the solutions. So, you can supplement with digestive enzymes, you can supplement with amino acid powders, and you talk about free-form amino acid powders and the importance of those, especially with vegetarians. We can supplement with vitamin Bs and B12, B6, folate, etc. And these are very simple things to supplement. And you also make a very strong case for lab testing. So testing patients with various different labs, and you give a very helpful list of the labs that you would recommend for these patients to then detect the deficiencies and then address those deficiencies with supplementation and diet. And I think, it's such low-hanging fruit. It seems crazy that more people aren't treating eating disorders in this way, to me. But one of the fascinating things also is, in the beginning, you talk a lot about sort of, the biological component of starvation. So essentially, eating disorders, there's a sort of starvation mechanism, and then it becomes a vicious circle, because the more the patient starves themselves, the more malnourished they become. And you talk about something called malorexia, if I'm not mistaken, which is essentially, malnourishment, if I understand correctly. And what is the initial cause, though, of that starvation? And I think that's where it's not clear. I mean, is it trauma? You talk a lot about trauma and stress. You talk a lot about eating disordered patients being incredibly anxious and having this level of anxiety that's so overwhelming that one of the only ways that they can control it is by controlling their eating. You talk about ACEs, so adverse childhood experiences, which essentially can lead to inflammation of the brain, which can lead to, disordered eating. And I guess I'm fascinated always by the root cause of these things. Is it that all of a sudden they just start starving themselves because of cultural norms and they want to look better? Is it because they have this sense of dread and fear that they're trying to control? Or could it also be that they just lack certain nutrients in their diet just because they have a poor diet or poor absorption, or genetically they're predisposed to poor diet or poor absorption, that then leads to mental health issues, which then, say anxiety and depression, which then leads to the disordered eating? I'm curious in that mechanism. So what causes this starvation, which then sets them on this path, this vicious cycle?
Well, the answer is all the above. So I can share with you stories, specific, very detailed stories of almost all the examples that you just described. There is going to be a patient A. Let's take all 14-year-old girls to start. Patient A, the pediatrician told them, "You're 10 pounds overweight." They were home during the pandemic, started looking at social media, lost the 10 pounds, but then kept losing and couldn't stop, and developed an eating disorder. So that initial motivation was some physician saying you need to lose weight, and not understanding that she was at risk for an eating disorder. The next 14-year-old girl might just decide to go on a vegan diet, and over time, restricting nutrients like zinc and B12 and amino acids, the brain just shifts. The next patient could be trauma. The next patient could develop celiac disease within that year and start having malabsorption of multiple nutrients. The next patient could be in a family dynamic of stress and trauma, alcoholic parent, and just stops eating. And then that stop eating because of anxiety ends up to be an eating disorder. And then the other one you mentioned is this pervasive anxiety. So we see a lot of comorbidity, is the term, with obsessive compulsive disorder. So these are individuals who, very rigid, obsessional thinking, sometimes compulsive behaviors. And if it latches onto food or body image, that can be that very rapid train to anorexia or an eating disorder. And it's quite common that we see an underlying OCD becoming an eating disorder that is more medically compromised or even life-threatening. So a long-winded answer, but all of your theoretical guesses, happen every day. And that's why we have to really individualize the assessment and treatment.
Yeah, and I think that's really important is unravel for each patient their particular set of circumstances, whether they're, emotional circumstances or biochemical circumstances that have contributed to this eating disorder, because that will unravel a personalized treatment approach, which is so important. You also mention in your book about PANS and PANDAS being sort of often comorbid with eating disorders. And I was very interested in that, PANS and PANDAS being pediatric well, better than I do, but essentially often caused by an infection, which causes inflammation. And how is that then linked to eating disorders?
Well, we're not sure the mechanism, but it's increasing. It's very common. The infection originally was thought to be strep, but now we see it across multiple tick-borne illnesses and Lyme. But after an infection, there's likely some autoimmune changes that affect the brain. And these often result in very challenging eating disorder treatments, because standard therapy, standard medications, even nutritional supplements aren't always as effective without addressing the underlying infection.
Okay. And I know that those are very complicated to treat, or they can be very complicated to treat, but they're, and there's a big link with OCD as well, and PANS and PANDAS. And I find the two really fascinating in terms of, the mechanism, whether it's inflammation or, the comorbidities as well. And they're very, very debilitating illnesses, which I feel very few people really know how to treat well.
Which is why it's really critical that individuals that are thinking of PANS find both pediatricians and psychiatrists and medical physicians that are very experienced in treating PANDAS and PANS.
Yeah, absolutely, which is hard to do, especially in Europe, I think. But anyway, omega-3s, another very important essential fatty acid. There are 3 of them, DHA, EPA, and ALA, which again, in vegetarianism tend to be very limited, but are absolutely crucial to, brain health. And, we know that it's the ratio of omega-6 to omega-3, which is important. But essentially, there's this sort of paradox, because patients with eating disorders often feel, we want to avoid fat, and fatty foods. But the problem is fats are absolutely crucial to brain health, especially essential fatty acids. And that's another one that you would recommend supplementing with to try and, because ironically, you mentioned that omega-3s and, can actually reduce weight, if I'm not mistaken.
Yeah, we've over the years recommending omega-3 fatty acids, probably now for 20 years. Initially, our patients, because it wasn't as common, or the internet, they would refuse because the 10 calories, and it was the word fat. Now we're not finding that challenging for patients to take some essential fatty acids, because if they're not familiar with it, we can share with them the literature that it's related to brain health, it's related to anxiety, to digestion, other physical ailments they might have, like allergies or skin rashes. So oftentimes we can kind of convince them the omega-3s are critical, and they'll take that as a supplement. They might, subtract the 10 calories somewhere else, but they'll take the omega-3s because it will help them.
Okay, so that's pretty great. The other fascinating nutrient that you talk about is lithium, which the statistics on lithium I thought were absolutely incredible. The ones that you mentioned. So there was a study done in 2020 in a rehab with about 425 patients suffering from substance use disorder, and they were given 150 milligrams per day of lithium, which did not impact their serum lithium levels, which is key. They should not impact they shouldn't show up. Lithium should not show up in the blood. But their use of medications to address opiate abuse was reduced by 50%. Their use of benzos was reduced by 99%. Their polypharmacy was reduced by 79%, and 300% increase in smoking attempts to quit, essentially, which these results seem to be slightly miraculous. Now, you talk at length about the benefits of lithium, both in terms of, the health of the neurotransmitters, but also brain-derived neurotrophic factors and other factors which, enhance sort of the, brain neuroplasticity, et cetera. You've had fantastic results with lithium across the spectrum, I think, in terms of psychiatric illness, but also in eating disorders. Can you tell us a little bit more about that?
Sure. Of every book that I've written, lithium somehow ends up. The research is quite extensive, and people kind of don't always realize that lithium is an essential mineral. It's in the periodic table, it's in the earth, and it's essential for brain function. And I believe, like every other nutrient, we have individual varying needs. And in the study that you discussed in substance abuse, I'm quite convinced that those with family histories of substance abuse, addiction, bipolar, or suicide risk have higher needs for lithium. Mm. So by supporting that, we can support brain function. The 150 milligram dose that was used in that addiction study of lithium carbonate is only 28 milligrams of elemental lithium. So it was a small amount of lithium. And, in our practice for 35 plus years, we use 1 or 2 milligrams, sometimes 5 milligrams for lithium to support symptoms like irritability and mood lability. And it can be incredibly helpful. For our patients with anorexia nervosa who are essentially starving and malnourished across many, many areas, we've just found that the low dose lithium, particularly around that irritability, particularly with those individuals with family histories of bipolar or substance abuse, benefit from small amounts of nutritional lithium, occasionally pharmaceutical lithium, but most of the time these 1 to 5 milligrams is sufficient.
Yeah, and you talk also about how it reduces impulsivity, and it's had a marked impact on reducing suicidality, probably through its impact on GABA, because it enhances GABA and also reduces impulsivity. Seems like everybody should be taking lithium. I don't know.
There's certainly many authors who've written the headline, "Why aren't we all taking lithium?" But you did mention that the suicide prevention. I just got to kind of reiterate that, because there's probably nothing more completely understood in the scientific literature that lithium is anti-suicidal. It prevents lithium. The amount of lithium in our tap water varies, and those areas with higher lithium is less suicide, and those on even prescription lithium, anti-suicide properties. The literature is so extensive, and new studies came out within the last couple of years. So it's really something that has tremendous public health implications that we have to take seriously and understand how we can implement it to prevent suicides.
Yeah, that's so true. So if I sort of summarize your approach to nutrition, you talk about testing, and there's a list of tests in your book that you would recommend, but pretty much, even without testing, and I know this is slightly controversial, but would it not make sense to give patients with eating disorders or frankly, any psychiatric illness, but we're focusing on eating disorders, a certain amount of zinc, free-form amino acids, a small dose of nutritional lithium, a B complex, which covers all the Bs, which are all essential for the nervous system and the brain, a dose of omega-3s, digestive enzymes, and probiotics. I mean, it seems that there's very little downside to that approach. It would seem very logical that any psychiatric, certainly inpatient, but outpatient as well, would include those elements, essentially, and magnesium is the other one. I mean, why aren't more people doing this, and why is this not more common knowledge?
I've been asking that question every day, if not twice a day, for 25 years. It is mind-boggling. I think early on, it was clear to me that the eating disorder community, kind of needed to see this as a psychological illness, a disorder of willpower, a disorder of disturbed family dynamics. And it's just a matter of helping somebody through the eating disorder. As we've better understood the biological based disturbance that we can see now on PET scans, that the brains of our anorexic patients are different, their genetics are different. People are more open now to think about medicines, more open to understanding as a brain-based illness, and occasionally more open to throw in a vitamin, a thiamine, or a multivitamin, but not really the comprehensive list you just mentioned, which would be helpful. And certainly the list would be much smaller if we started that with our 10 and 12-year-olds who are just beginning to restrict their diet or beginning to get hooked on social media and comparing themselves with others. So we can, with this model, develop a prevention program for those high-risk individuals and prevent this illness.
Yeah. And I mean, one of the interesting things also, which I heard you say at some point, and I don't remember reading this in your book, but, we talk about the importance of serotonin in terms of body image. And one of the issues is body dysmorphia, which is where you look at yourself and you think you're really, really fat, or you're fatter than you are, and you're actually very thin. You gave a very interesting sort of evolutionary explanation or theory that somebody, a scientist, I can't remember his name, had come up with, which was that, if somebody who was a hunter-gatherer looked in their reflection and saw somebody who was emaciated, then they might sort of curl up and die as opposed to go on the hunt for food. And so it was in their evolutionary interest to see themselves as healthier and fitter than they actually were. I thought that was quite interesting. But I've always understood that serotonin levels can very much impact the way we see ourselves, and can, behind body dysmorphia can be low serotonin. And serotonin, of course, being linked to the correct amino acid tryptophan and also zinc, B6, those cofactors are essential for serotonin production. Would you agree that serotonin is crucial in sort of the body dysmorphia area? And obviously we know that it also regulates mood and appetite, etc.
Yes, absolutely. I think in the appendix of this book, the Sean Gussinger is a PhD who has that theory adapted to famine, these different genetic vulnerabilities that might have been more helpful 10, 20,000 years ago. And she develops that, and she's completing a book on that. I think it's powerful. It's powerful for parents to understand that it's nobody's fault, for patients to understand that is a kind of a genetic vulnerability that makes your brain work differently when you're malnourished and restrict. So absolutely, serotonin is critically important for our treatment of OCD and body dysmorphic disorder, and often anorexia. But I think it might often come down to genetics, because we're also genetically vulnerable to differing ways of synthesizing serotonin. Our serotonin receptors might work differently, as well as these nutritional cofactors. So it's a whole host of metabolic issues that kind of converge on how our serotonin system would be functioning for each individual.
Absolutely. And one of the tests that you recommend is a genetic test. I mean, you talk about the MTHFR gene, but I think there are other genetic tests as well, which I think are important to look at the metabolism and, our neurotransmitter, our sort of genetic tendencies to processing neurotransmitters in different ways. That's always very, very helpful. So in terms of, you have this very wonderful list, and I'll just run through it very quickly for our listeners. You recommend an amino acid panel, fasting, a complete blood count with differential comprehensive chemistry panel, celiac disease screening, EFAs, which are essential fatty acids, folate and B12, homocysteine, iron and ferritin, cryptopyrroles, lipid panel, magnesium, MTHFR, which is the genetic test, red blood trace minerals, oats, which is organic acid test, which is a urine test, vitamin D, zinc, and copper. And, again, I mean, the only prohibitive thing about this is, the expense. It can be expensive to do all these tests. But if you're able to afford these tests and you have access to a physician who can do these, I think it's absolutely essential to do these and then treat accordingly. But even as I said, if you don't treat, I think taking that handful of supplements that are sort of the basic supplements can only be helpful. Now, in terms of, obviously, we've covered the nutritional part. Now, your book also talks about therapy, the psychological part, which is much better covered, obviously, in mainstream medical approaches to eating disorders. So we won't dwell too much on them, but sort of the traditional therapies for eating disorders tend to be CBT, cognitive behavioral therapy, DBT, and FBT, which is family-based therapy. And DBT is dialectical behavioral therapy, which focuses more, if I understand correctly, on sort of becoming aware of your feelings. CBT, cognitive behavioral therapy, is more sort of becoming aware of your thoughts that then link to certain behaviors and then intervening. And one of the fascinating points in your book, which I found really interesting, was you said that patients with anorexia tend to exhibit less mindfulness, less ability to be aware of their thoughts and of their feelings than other people. Can you talk a bit more about that? Because that seems really interesting and crucial in the treatment.
Yeah, there's been some newer research looking at relationship between autism spectrum and patients with anorexia. Sometimes the rigidity around the OCD kind of minimize any kind of emotional connection. And what we have found clinically is our patients don't necessarily have the kind of emotional range of depression and sadness and joy. And some of our patients would look at us without any affect or sadness, saying they're feeling fine, and then try to kill themselves the next day. So, and I believe this is all directly related not to the patients with anorexia nervosa, but to those that are in a starvation state, because their brain is just not functioning to capacity. I see this with people sometimes on antidepressant medication. There's a bluntness, lack of emotion. So I believe it's part of this malnutrition. And as they get more nourished, they're better able to express feelings and articulate both motivation for recovery and hope for recovery.
I mean, that's fascinating. And then a couple of things I wanted to come back to. In terms of the mindfulness, I mean, you talk a lot about how mindfulness, yoga, meditation, and therapy can be very helpful in terms of, enhancing sort of body image and body awareness and awareness of thoughts, etc. And you talk about yoga, particularly in relation to the more spiritual, meditative types of yoga rather than the athletic ones, which could just be sort of excuses to do more exercise. So I think that's very interesting. A couple of things I wanted to cover as well was medication for eating disorders, because I know that you're a traditional psychiatrist. You also can treat with psychotropic medication, and you have at times. And so what is your approach? I know that's sort of mainstream psychiatry often gives SSRIs and other psychotropic medication for eating disorders. What is your view of that? And you yourself, as a treating psychiatrist, I know that you have treated with antipsychotic, for instance, and you've had some success with that. Could you tell us a little bit about your approach to medication with eating disorders?
Sure. I mean, I think if we divide the eating disorders into the three largest categories, binge eating, bulimia, and anorexia nervosa, a binge eating disorder, we have approved medications, and medications do work. There are about 3 or 4, and binge eating is actually more common than anorexia and bulimia combined. So there is medication that can be incorporated into a therapeutic program.
Which one for binge eating? Which medications?
Well, Vyvanse is approved, but we also use medicines like Topamax, naltrexone, and sometimes the antidepressants. But after a nutritional evaluation and workup, if medicine is needed, we can really stop and treat binge eating disorder to 100% remission. Bulimia is more challenging. Prozac is approved, but not often sufficient. And for anorexia nervosa, there's actually no FDA-approved medication. And one of my pet peeves is the quick reflex to use the antidepressants, the SSRIs, by many doctors, because we have no other tools. They're knocking on our door, asking for meds, and parents are looking for something, and they will say, my child is depressed, let's give them an antidepressant. My experience is, particularly at the lower weights, the antidepressants, one, don't help, and we have research to support that, but they also get in the way of treatment. They slow progression of treatment. That is just my clinical opinion, not research. But the research has demonstrated antidepressants do not help anorexia. So what we have found for individuals that end up in a hospital or a residential treatment program where they're unable to eat, the intensity of the fear, the anxiety, they're paralyzed, they cannot put food in their mouth. And we have found this low dose of some antipsychotics, olanzapine being, I think, the most helpful, has really decreased some of that rigid thinking and put someone on a path to a therapeutic program.
Interesting. And why do you think medication works better with bulimia and binge eating disorder than with anorexia?
I mean, it's likely due to the starvation. I mean, these medications kind of manipulate neurotransmitters. And as you discussed with serotonin, you need protein, you need the tryptophan precursor, you need vitamin D and all these other cofactors. So medications don't have much to work on with someone who is profoundly malnourished or that state of malorexia.
Interesting. Okay, understood. And I mean, you do make the point that by addressing these nutritional deficiencies, you have a much higher rate of success with both, pharmaceutical drugs, but also therapy, because the patient is in a much better place to be able to benefit from therapy. So either way, whether you don't want to take any meds, or if you want the meds to work better, taking these supplements and making sure that your nutritional status are up to par or is up to par seems to be essential.
Yes, no, I agree. It's not, this book focused primarily on nutritional psychiatry because it's so missed, but we're not discounting the role of therapy or medicines or nutritional support. They're all important. But without that biological foundation of, your brain working, nothing else makes sense.
Nothing else makes sense. And another interesting thing I noticed was that a lot of patients with eating disorders with anorexia then go on to develop binge eating and bulimia later. I think it was something like 30% of these patients. Do you know why that is? Do you know why there can be a progression to binge eating and bulimia?
Well, I'm going to come back to the same thing with these nutritional deficiencies. So the disorder is kind of partially treated. The disruption in both brain function and the emotions and the thought processes are still kind of active. And, many patients fluctuate between different illnesses and can start binging and then a year later just restrict. And it can be a wild kind of roller coaster ride of disordered eating. And my experience is that's because the core problems were never addressed.
Understood. And another thing that struck me when I was reading your book was, the traditional therapies for eating disorders, whether CBT, DBT, FBT, because it's such a body-based disorder, I would have thought that somatic experiencing EMDR, somatic therapies, which are more based for trauma, would be worth trying with eating disorders, because they're therapies which work specifically with trauma, and they have much higher success rate with trauma and ACE experiences than the more cognitive therapies. And they work with the body and with cellular memory. And they've had very, very high rates of success with traumatized patients, with patients who've suffered from adverse childhood experiences. And I was surprised not to see more of these therapies listed. Do you think that that's something that needs to change? Are you aware of the whole sort of somatic experiencing movement? And in your experience, have you found that these body-based therapies, do you think, could work better?
There's certainly an important part of the treatment plan. Recent studies done in a residential program that have clinics around the country found that over 50%, over 60% of adults and 50% of kids met criteria for post-traumatic stress disorder. So we know that trauma plays a role in eating disorders. We know untreated trauma plays a huge role in poor outcomes. So absolutely, many trauma-based therapies can be effective and should be incorporated into a treatment model. Again, our ability when we're malnourished to use traditional psychotherapy is kind of meaningless because our brains are distorted and cognitively impaired. But oftentimes, some of the more somatic-based therapies can just provide an inroad to some relief.
Yeah, and the other thing I was thinking was, when you talk about that high level of anxiety that these patients experience, whether you could do nervous system regulation therapies, to try and regulate the nervous system. So, for instance, the work of Stephen Porges, the polyvagal theory, and, working on the nervous system, I would have thought would be a great adjunct therapy for patients with eating disorders to try and regulate their nervous system to the point where, they're not crippled by anxiety, in tandem with the nutritional approach, which you advocate, I think could be incredibly powerful.
Yes, we've been using for over a year now, biofeedback groups with heart rate variability, both individually and groups throughout our inpatient and residential programs, and patients find it very helpful.
Very helpful. One thing you mentioned also, and then I'll go on to relapse prevention, because that's a very important point as well. You mentioned that the PET scans of patients with anorexia were different, or showed differences in brain, presumably volumetrics. Can you expand on that? Like, how are their brains sort of different from an imaging perspective?
Well, I mean, what I can share with patients and parents is that their child's brain is working differently. And so if we look at a milkshake or something, to certain parts of our brain would light up and we'd be motivated and we'd want it. Our brain would want it. And it would be kind of the opposite part of the brain, not really opposite, but different parts of the brain with someone with anorexia. So the wiring is kind of mismatched. And we can see that in a couple different parts of the brain. And some of that is just awareness. Some of that has to do with perception of a body image. So, I think it hasn't translated into how we can treat differently, but it certainly helps acknowledge, again, what I said, that we can stop blaming, these kids for doing this on purpose, or parents, and taking that blame away with some of these biologically based explanations just kind of sets the beginning of treatment on much more of a medical course.
Understood. And that brings me to something that you were talking about in terms of relapse prevention, which I thought was great, was, you talk about instituting an unconditional listening process, because you talk about how, patients with eating disorders often self-shame, they self-stigmatize. And there's a lot of stigmatization from others as well, because it's sort of like, well, you're controlling this, you're controlling what you put in your mouth or what you don't. And that hadn't really occurred to me, but it makes it very different from other mental health issues in the sense that, in some sense, you do seem to be in control. The patient does seem to be more in control. And that can be paradoxical because, then there is this sense of sort of self-stigmatization, as you talk about, and a tremendous sense of shame and guilt, you talk about in the context of relapsing, but that does seem particularly tragic. It's sort of like adding insult to injury. And I liked your idea of talking about this unconditional listening process. And in terms of, you talk about the relapse rate being so high and, your 5 steps to preventing relapse. You talk about 33 to 50% relapse rate, which is highest in the first year after treatment. And it's the highest of any sort of mental health issue is eating disorder relapse rates. So you talk about, one, providing optimal nutritional support, and you talk about the fact that essentially relapse often is the result of a failure to address these nutritional deficiencies that we've been speaking about. You also talk about assessing and treating co-occurring mental health disorders and substance abuse. The third point was monitor and reevaluate during times of increased stress, because then there's more vulnerability to relapsing. Instituting an unconditional listening process to listen without judgment, because shame and guilt are such key drivers. And then find meaning in life beyond the eating disorder. And I thought these were all very, very helpful. Have you found that implementing these has really helped you turn around the relapse rate in your patients?
Yeah, like anything in medicine or maybe psychiatry, what we share with our patients and our families is not always easy to follow through and for all life circumstances. But absolutely, I think those 5 steps are core. Somebody could be doing really well and they have a bad weekend and the parents are just yelling, or the spouse, and, really negating and starting that shame and guilt. And that could be the one of those, areas that just push someone back into restrictive eating. Or it could be stress, a loss of a, parent or child, or divorce. Any of those things could just create that cycle. But if with a good team, therapist and physician, to kind of help support all those areas, we often can clearly keep someone on a path that they work so hard for, because it's not easy. They work so hard for recovery that by understanding and juggling the nutritional and the psychological, we can keep them on that path of recovery.
Which is key. And one other point that you mentioned, you talk about refeeding, which can inadvertently compound nutritional deficiencies. I thought that was fascinating because you talk about how when you refeed patients with eating disorders after the initial adjustment to increase food intake, the body increases its metabolic rate, which then increases intrinsic requirements for nutrition and calories. And then zinc deficiencies, for instance, can then skyrocket. And so this seems to be something that one should really be aware of, that it can backfire, this refeeding, because it increases your metabolism and can then essentially create nutritional deficiencies or exacerbate them. Is that something?
Yeah, there are 2 terms. There is refeeding syndrome, which is a life-threatening syndrome of someone who is restricted eating for long periods of times and will eat too quickly. There are lots of metabolic changes that can be life-threatening. And so that is someone monitored in a hospital or careful monitoring. So that's refeeding syndrome. What you're describing is just so common and commonly missed is as our patients start to refeed and eat and develop a better understanding that to stay healthy, they need to eat, their metabolism starts to work and they start to utilize nutrients. And one of the better studies done in a research unit that I quote in the book is they measured the zinc before and after a 30-day study. And even though they were getting the RDA of zinc in their diet, their zinc levels plummeted on discharge at 30 days because they needed more than the RDA from food. And that's one of our arguments for additional supplementation during this refeeding process.
Interesting. And then another point that you make, in terms of your fifth point, which is very much about finding meaning in your life. You mentioned in your book that a lot of patients with eating disorders, sort of weight control and nutrition control becomes very much their sort of purpose in life. And, they feel good about themselves because they can control their weight and their image, etc. And you talk a lot about how important it is to find things external to that as sort of meaning, whether it's helping others or their career or their, and it seems to me that's absolutely essential. And I think you describe it really well. And have you found that that's one of the key factors? I mean, what of these factors, if you had to separate them, obviously the nutrition is key, but which are the key, sort of the top three key factors that for you determine success as opposed to relapse?
Well, I don't know if I'll pick 3 out of the 5, but I certainly the meaning and purpose has to be number 1, because I can't tell you when someone hears that I do this for a living, they'll tell me their story. And lots of patients over the years, these people, 40, 50 years, it was some, profound experience, either religious experience, they went back into the church or their religion, or they went back into a relationship or back into a job that had meaning, which is how they got out of their kind of rigid eating pattern. So those I hear all the time. But I think with our kids and the illness starting so young, seeing 12-year-olds really impaired, I think the nutritional repletion factor, has to be number 1. With that direction of meaning and purpose, because the tendency to focus or over-focus on food, most of these brains, they can over-focus on other things, school, work, and that's why tend to be very successful people. And if we can shift them out of the patient eating disorder focus, then they're often very successful in careers and their lives.
And I think that takes me just 2 more questions, then I'm going to let you go. But one of them is social media. There's obviously a huge argument saying that, all these mental health issues, suicides, et cetera, have increased in young people since 2011, 2012 with the advent of Instagram and Snapchat, and that social media has a lot to answer for in terms of presenting these impossible images to especially young kids. What is your view on social media and, its role in eating disorders?
I think the simple answer, it has a profound effect on our kids. And the term I frequently use now, it's the gasoline on the fire. Some of these genetically vulnerable kids, social media can be what really transforms some body image issues to a disordered eating pattern. I think it's wrong to say social media causes eating disorders, but absolutely can sink kids into a black hole of really self-destructive, both images, self-esteem, and isolation. That is kind of the tinderbox for serious illness.
But presumably, if we make sure that their nutrition is balanced and that they aren't suffering from all these nutritional deficiencies, it will make them more resilient and robust when faced with the inevitable images that they're being bombarded with.
Yes, but I think we absolutely, as adults, have a better need to take a better role and responsibility for limiting some of the social media, certainly the way they're targeting these kids. And targeting particularly women who are looking at weight loss or body image things. So there's a lot we can do. I can't boil it all down to nutrition, but social media is just one factor that we can do something about.
we can try to limit it as much as possible. It's not always easy, though. As a mother of teenagers, it's very difficult.
Absolutely. Yeah.
Yeah. And then my final question is just in terms of the approaches that we've discussed, would you say that they are similar for anorexia, binge eating disorders, and bulimia? I mean, we've talked about the difference in pharmacological approaches, but in terms of the overall approach, are there any differences that you would want to highlight between the approaches that we've discussed for each type of disorder?
Yeah, I think Binge Eater probably has a life of its own, and maybe a separate show where we have a different book. So I think again, it's easier. So I'm very hopeful and want to make sure people know that recovery is 100%. That the anorexia is a unique and bulimia, challenging illness with a constellation of genetic and multiple environmental risk factors. The most important thing I can share is the earlier and more aggressive treatment in our young teens, the much easier it is to prevent a life-threatening outcome.
Yeah, and I mean, you do say that, and I do want to really stress this. I mean, you say it. This is a quote from you: "The longer anorexia lingers, the harder recovery becomes, and the more likely it is that the physical consequences of starvation may inflict lasting, if not permanent, damage to your child's health." The single most important piece of advice that I can share with you is the earlier you seek treatment for anorexia, the better. And I think that's very important. I mean, obviously that's anorexia, but presumably any eating disorder, the sooner you treat it, the better.
Correct.
Absolutely. Well, look, thank you so much, Dr. Greenblatt. Is there anything that we have forgotten or that you would like to cover that we haven't mentioned?
No, I think we hit most of it. I do think the theme of every child might be different. We can't always compare. And the only thing I think we didn't mention, but is I think really important for anorexia, is the overlap with celiac disease, which is common. And sometimes there might be no GI symptoms, just the weight loss. And I'm just very disturbed that our pediatricians and child psychiatrists aren't routinely checking for celiac disease with someone presenting with an eating disorder. And I think they should.
Absolutely. And the link there, which I thought was fascinating, was not only, if you have celiac disease, you can share symptoms with anorexia, so it can be hard to tell which is which, but also if you're diagnosed with celiac disease, that can then trigger an eating disorder because you have to avoid gluten, and you have to restrict your eating. And that actually led me to another question, which I don't want to ask you now, but I can't help it. With this whole trend of, gluten-free, everybody has gone gluten-free and dairy-free. Is there a risk of increased eating disorders due to this sort of consciousness of wanting to avoid certain foods for health reasons?
Absolutely. I hear that story, I would say every day, but I'm exaggerating. So I would say twice a week, without doubt. And I spoke to a family 2 days ago, a young woman who was sick and went on a restrictive diet and helped her tremendously, her autoimmune disorder, but triggered an eating disorder because she was restricting, the diet. And nobody was monitoring B12 and zinc and D. She was profoundly deficient. And now she can't eat any food and has a serious eating disorder requiring hospitalization. But it started off on a healthy approach and just not monitored.
Well, it's fascinating. And there is a disorder called orthorexia, which is where, people are obsessed with what they're eating and the health of what they're eating. And so they become very restrictive and very obsessive about sort of, avoiding certain foods and eating super healthy. And, at what point does a sort of healthy approach to eating, then can it tip into sort of an unhealthy approach termed orthorexia or whatever you want to call it? Do you have a view on that? I mean, it's not straightforward.
Well, I have a distorted view because I see that every day in a hospital, many patients starting off with what you and I would call orthorexia and ending up to be requiring medical admission because of malnutrition. So that the line is different for everyone, but when the eating starts to impair, some functional aspects of their life, work, home, family, being able to go out with other people, then that line is crossed and it is a path to a serious eating disorder.
That's fascinating. Well, I must say, Dr. Greenblatt, you're amazing. And I'm so grateful for your time. I'm so grateful for your wisdom and for the work that you do, which is absolutely crucial and saves lives. And I would highly, highly recommend your book. I have it in a PDF form, so I don't have it in hard copy to show, but Answers to Anorexia. And, keep up the great work. And thank you so much for the work that you do.
Well, thank you. And I appreciate your opportunity here being on your show. Take care.
Thank you. Thanks so much, James. Take care.
Thank you so much for listening to the Mind Health 360 show. I hope that we've helped you realize that mental health symptoms have root causes that can and need to be addressed in order to sustainably heal, and have given you some ideas about steps you, your loved ones, or clients may take to start their healing journey. Please share this interview with anyone you think may find it helpful, and don't forget to subscribe to keep up to date with our latest interviews on integrative mental health. If you want further information, please go to www.mindhealth360.com or find us on social media. This information is for educational purposes only and is not intended to diagnose or treat any disease or to replace medical advice. Please always consult your healthcare practitioner before discontinuing any medication or implementing any changes in your diet, lifestyle, or supplement program.